Today's podcast will cover Chapter 1 in the ICD-10-CM Codebook, Certain Infectious and Parasitic Diseases. We'll be looking specifically at the guidelines. The first guideline is to code only confirmed cases of HIV. There are certain conditions that we only code confirmed cases. One is HIV, one is epilepsy, one is Zika virus, and most recently the coronavirus. But we'll cover those in the chapters as we go forward. In our scenario, a patient admitted with anemia with a possible HIV infection. The key word a coder is going to pick up on is the word possible, because we know we code only confirmed cases. So we would code the anemia, where it talks about in an inpatient setting, if a physician says probable, possible, most likely, those kind of things, you would code it as though it exists. But the way this is written, this guideline is written, it tells us this is an exception to that guideline on the selection of principal diagnosis. Some guidelines talk about HIV-related conditions, and coders may ask, well, what is an HIV-related condition? There's a list in the policy and procedures of the coding department where you might be working, and you can also find the list on the CDC.gov's website. Here are examples of what would be considered an HIV-related condition. Anytime you see what the physician calls an opportunistic infection, you get the candidiasis of the bronchi, trachea, esophagus, or the lungs. And an example of candidiasis is oral thrush. The yeast infection is Candida. That's why he's called a candidiasis of these body structures. The cytomegalovirus, particularly retinitis, abbreviated as CMV, histoplasmosis, Kaposi sarcoma, and pneumocystis carinii pneumonia. The ones that I have seen most frequently are the candidiasis, the Kaposi sarcoma, and the pneumocystis pneumonia. Note that this is not a complete list. You would have to look at your facility's policy and procedures to see what would be considered the HIV-related conditions that you would code. The Coding Clinic is a publication that helps coders understand how one might code a situation, and in this way we would all be coding it the same way, therefore you could compare data. This particular question came from a coder. It was published in the first quarter of 2019. Coding Clinic is published 4 times a year. In the first quarter of 2019, a question being, we had been advised by an outside source that we are to assign code B20, the HIV disease, for every patient who is HIV positive and is treated for any condition that is listed in the MSDRG definitions manual, including viral and unspecified pneumonias and other conditions that are not included in the CDC's list. We've used both lists for years to determine when an HIV-positive patient has had a documented AIDS-defining illness before we would assign the AIDS code. Would you please clarify when we may report code B20 in the absence of provider documentation that the patient has AIDS? In other words, because the patient had one of these AIDS-related illnesses, they are being told by an outside source, which is probably the insurance company, but I'm not sure. It may be a vendor. It may be someone auditing the chart. They don't agree with it, so that's why they're going to Coding Clinic and asking the experts and want to know, okay, we don't have any provider documentation the patient has AIDS. So when do you code B20 if you don't have that documentation? And the answer that was given to them is that provider documentation must specifically indicate AIDS, or that the patient has an HIV-related illness prior to assigning code B20. In other words, the physician might say, this is an HIV-related illness. Well, then you've got your documentation. But without that, you can't link a diagnosis as HIV based solely on the CDC list or the conditions included in the DRG list. If the documentation is unclear or ambiguous, the provider should be queried for clarification. Later on in the semester, we'll talk about queries, templates that are provided by the facilities so that a coder can ask a physician for clarification. So here we've got a patient admitted with pneumocystis due to pneumocystis carinii and has HIV. This is an opportunistic HIV-related condition. So the physician has documented this, so we're going to code the B20 and also going to code the pneumocystosis. Now here's a patient with HIV that's been admitted with an unrelated condition. In other words, it is not on those lists, whether provided by the CDC or the DRG manual. You would be coding only the condition and then your HIV. You would be coding the condition as your principal diagnosis, and then the B20 would be your secondary diagnosis. The documentation has to tell the coder the patient's admitted with anemia. He or she has HIV infection, but this anemia is not due to HIV. And the guideline tells the coder how to code that. Here's a guideline for a patient newly diagnosed with HIV. This patient has developed numerous lesions related to Kaposi's sarcoma of the skin. This HIV infection was confirmed in the early days of this hospitalization. So this patient did not know he had AIDS until he had developed these lesions. He comes into the hospital for treatment. The HIV is then diagnosed. So the guidelines tell us we would code the B20 as our principal diagnosis. Then we would add the Kaposi's sarcoma of the skin, multiple sites, as our secondary diagnosis. There are times a patient can have HIV and be asymptomatic. This patient is admitted with appendicitis. The patient is HIV positive, but there's no symptoms. There is a code for asymptomatic HIV infection status, which is D21. So that would be listed as your secondary diagnosis because the patient's admitted with appendicitis, which is not related to the HIV infection. This is the same scenario, but I'm adding that his medication regimen includes 2 different medications for the HIV. And the guidelines tell us that the use of medications is not an indication that B20 is used instead of Z21. He is still asymptomatic. Yes, he's on medications for the HIV, but he is asymptomatic. He is admitted for the appendicitis. So your appendicitis remains as your principal diagnosis and your asymptomatic status of the HIV as your secondary diagnosis. I have not seen this very often, but the guidelines are here for a reason, so we have to always look at them. Here's a patient I mentioned earlier, admitted with appendicitis. This patient is HIV positive, and last year he was hospitalized with pneumocystis pneumonia. And what this tells us is that once a patient has been diagnosed with HIV-related illnesses, no matter how long ago it was, that B20 diagnosis is going to always follow them. So he or she is not going to be a Z21 any longer. She will be a B20 AIDS diagnosis going forward. It is not the principal diagnosis because she is admitted with appendicitis, which is not HIV related. So you would have the same appendicitis code as your principal, and then the HIV disease B20 as your secondary. Chapter 15 is in the code book. This is specific for pregnancies. And what you remember as a coder is that the codes that are related to pregnancy always take priority. I don't know of one situation I can think of where they didn't. So the patient's a 27-year-old with an oral thrush, which is associated with her HIV positive diagnosis. She's 13 weeks pregnant. She was asymptomatic before this hospitalization, but now she's got this thrush. It is an opportunistic infection. So she is going to carry that B20 diagnosis, but it is not the principal diagnosis. You would go to Chapter 15 codes, and you would have to code the pregnancy complicated by the HIV disease as a principal diagnosis. That 6th character, the 1 there, is indicative of the first trimester of the patient's pregnancy. We'll cover that a lot later in the semester when we do coding for pregnancy. The point to remember here is that the pregnancy code goes first, then the B20 code, because now she's had this thrush. She's not asymptomatic anymore. She's going to get that B20 code. The oral thrush is coded, and the weeks of gestation. This guideline, we're going to get away from HIV disease, and now we're going to talk about other diseases where the infectious agent that's causing the disease is in another chapter. It's not in Chapter 1. Some codes in Chapter 1 are described as whatever condition it is due to this organism as part of the Chapter 1 code, but not all the infectious organisms are in Chapter 1. So that's when you would code whatever infection it is, along with the B96.20 code. The reason why you have to have the B96 is because the N39.0 just says the patient has a urinary tract infection. It does not tell the reader what's causing that infection. We know from the diagnosis in the scenario that the infection is caused by the E. coli, but there's no code in the chapter for the urinary system that gives that information. So the coder has to code the infection and then the cause of the infection. We're helped by the instructional note under the N39.0 code that says use additional code to identify the infectious agent. And the range it gives us B95 through B97. So we know we're going to be somewhere in that range. If we look up infection in the index, there is an entry for E. coli, not elsewhere classified, which is NEC, as the cause of disease classified elsewhere. The disease is classified in the chapter for the urinary system. We would need both codes to accurately describe this scenario. I want you to note in the instructional note where it says use additional code, that tells you it is a secondary code. It is not the principal diagnosis. There are other instructional notes that might say code first. This one says use additional code, so you know it is not the principal. There are infections that are resistant to antibiotics, and it's important that we code that because there's our data is collected about just about anything in the medical field, and one of them is resistance to the antibiotics we currently have to use. I used the same scenario where the patient was admitted for treatment of a UTI caused by E. coli, and then the doctor adds the infection is resistant to vancomycin. There is an entry in the index under resistance organism to drug vancomycin. So this would be one of our codes. As part of this guideline, it tells us that many bacterial infections are resistant to the current antibiotics that we have available to us. So it's necessary to identify all the infections documented as antibiotic resistance. Category Z16, resistance to antimicrobial drugs, following the infection code only if the infection code does not identify drug resistance. There are codes in the code book, specifically in Chapter 1, that talk about an infection which is methicillin resistant, for example, or methicillin susceptible. That is included in the code description. So what this guideline is telling us is you're going to use this Z16 category because these codes up here don't tell the reader that the infection is resistant to antibiotics. Patient is admitted with sepsis. The cause is not specified. So the times when a coder is going to code this A41.9 early on, and then later on when it becomes possible to identify the organism that's causing the sepsis, you would change the code to something that's more accurate. This guideline is just telling us if you don't know what's causing it, you're going to assign the A41.9. There's sepsis and there's severe sepsis, and they are two different things. The doctor has to document if it's severe sepsis before you can code severe sepsis. We're using the same scenario where the patient has a UTI caused by E. coli. Now he's developed severe sepsis and acute kidney failure. You would code that UTI in 39.0. Using our instructional note, use additional code, we would code the infectious organism E. coli. Then we would code the severe sepsis. And then we would code the acute kidney failure. There's an instructional note under sepsis, R65.20, that has several conditions, among them the acute kidney failure. So you're going to be sure you code that. Then I have a little note here. It's not enough in the coding world to just select the correct codes. They have to be in the correct sequence. And the guidelines many, many times tell the coder how to sequence the codes. And you might think, well, why does it have to be in a certain sequence? Well, the way the payment system, the DRG system, is set up, which we'll discuss later on in the course, and if you've watched one of the first podcasts about reimbursement, you'll understand this. This first code is what's going to drive the selection of the category or the group that this particular diagnosis falls into. So it's important that this code, whatever's going to drive your payment, is going to be first. Then when you have this first, you've got that instructional note telling you, okay, you need to include this. Then you know you have sepsis and the acute kidney failure. And here's when you have sepsis due to a post-procedural infection. Here the patients develop sepsis with MRSA, which is methicillin-resistant Staphylococcus aureus. The organism is Staphylococcus aureus. This is an example of an organism that's resistant to antibiotics. Methicillin is an antibiotic. Patient develops sepsis with MRSA infection of the superficial incisional surgical site following a total hip replacement. Note the guideline tells the coder how to sequence the codes. So you're going to code the post-op wound first. Then that tells you, and with an instructional note, use an additional code to identify the infection, which we're going to do. Then we have the sepsis. And then we have the sepsis due to Staph aureus. And I note here you can find two different ways to find this code, using either sepsis or MRSA as your main term. If you read the guideline here, it tells you how you're going to code this. You're going to code the infection first, then you're going to use an additional code for the sepsis, and then you're going to identify the organism here. The Zika virus is another one of those viruses that must be confirmed. We don't code possible Zika infections. Patient is infected with the Zika virus. Very direct. A92.5 is the infection code. You're only going to code a confirmed diagnosis. In this context, it tells us confirmation does not require documentation of the type of test performed. In other words, we don't care how the doctor knows this patient has Zika virus. The fact that he says the patient has it is good enough. Now we're going to code it, A92.5. Here the patient presents with a mild fever, skin rash, and joint pain. She has traveled outside the U.S. for the last 6 weeks. I think it is probable this is a Zika infection. As a coder, when you see the word probable, you're going to think about the things that you know you don't code unless they're confirmed. So we know we're not going to code Zika. We're going to code whatever her symptoms are, what she's presenting with, the fever, the rash, and the joint pain. And here, if the patient had had contact with someone that was Zika, contact with someone who had Zika, then you would use the Z20.828 code. But we don't have that in our documentation, so we can't code that. We're only going to code what we know are the symptoms. Now I want to talk about the coronavirus. It is not in your code book, in the 2020 code book, because it happened after the 2020 code book was published. Remember, October 1st is when the guidelines change. So the 2020 code book had been published in October. So we had no way of coding COVID-19 specifically. We had codes for the coronavirus, but not COVID-19. This was a new virus. So what's called interim guidance was published due to the pandemic in April. And the interim guidance then tells the coders, okay, we know you don't have a code for this, but it's really important we collect this data, so now I want you to code it this way. So they told the coders exactly how they wanted it coded. A new chapter was created in the 2021 code book, and through this interim guidance, called Provisional Assignment of New Diseases of Uncertain Etiology or Emergency Use. And it's U00 through U49. And the World Health Organization is going to be using that to follow these new diseases. If you're wondering why I didn't order the 2021 code book, the reason is I have to order code books way back in the fall. And one time I ordered the next year's code book and they weren't published on time, and it was not a good situation. So because I'm teaching you how to use the code book, I'm just going to make you aware of how we would code coronavirus, but you will not have it in your 2020 code book, and I won't be covering it on the exams. The chapter 22, which is found, if you look in your 2020 code book, the last chapter in the code book is chapter 21. So you know this is a new chapter in the 2021 code book, and it has this listing of codes for special purpose. What I want you to see is not just COVID-19. There was also a code created for vaping-related disorders. And you see the use additional code to identify manifestations. This is part of that code. And then when you get to COVID-19, it tells you use additional code to identify any of the manifestations of COVID-19, and it excludes coronavirus. There is an entry in the tabular and in the index for coronavirus because coronaviruses have been around for a long time. COVID-19 is a unique coronavirus that's caused all the problems that we are all so aware of. You may remember from your reading, excludes 1 tells the coder you cannot use this code, U07.1, and this code, B34.2. You have to use one or the other. That's excludes 1. In the alphabetical index in the 2021 code book, prior to the pandemic, you would have infection as your main term, then the coronavirus, as the cause of disease classified elsewhere, or the SARS-related pneumonias or respiratory problems. Then when the pandemic came along, now we have in the index infection, coronavirus 2019, U07.1. COVID-19 is what we call this, but in the coding world, it's coronavirus 2019. And we still have the coronavirus not elsewhere classified as a choice if it's something other than COVID-19. The guidelines for coronavirus, I'm not going to go into these great detail with these. This podcast is published as a PDF, so you can read it for yourself. What is important is only confirmed cases are coded. A presumptive positive is coded as confirmed. And if the provider documents suspected, possible, probable, inconclusive, you don't assign that U07.1 code. You would assign whatever's causing them to seek treatment, whether it's fever, whatever, and you might code the Z20.828 if you know the patient has been exposed to someone with COVID-19. It doesn't mean he or she has COVID-19, but you certainly need to code the contact. This tells you if the COVID-19 meets the definition of principal, it's going to be your principal diagnosis, followed by the codes for the associated manifestations, except obstetrics. Where you've got the pregnancy patients, you're going to have a specific code for COVID-19 in a pregnant patient. If COVID-19 progresses to sepsis, you're going to use a different guideline. And then this is chapter 15 guideline for the COVID-19 in pregnancy. COVID-19 infections can cause a couple of different acute respiratory illnesses, and these are the 4 that have been given to us as options with guidelines for each. Here's a scenario. A patient was admitted with 104-degree fever, severe shortness of breath. She returned from Italy 10 days ago. Her lab test was positive for COVID-19. She was diagnosed with pneumonia due to COVID-19, hypertension, and type 2 diabetes. Diabetes is treated with oral meds. So the coronavirus would be the principal diagnosis, your first diagnosis, U07.1. The viral pneumonia, and it's viral because COVID-19 is a virus, so it's a viral pneumonia. There is no code under pneumonia viral for COVID-19 yet. I bet there will be. So as of right now, you're going to code just specified because you know what it is. It's specified. Type 2 diabetes, hypertension, and the use of the oral meds for the diabetes. This is for those patients that have been exposed to COVID-19. You're going to code the C010-CM Assigned if there's a suspected exposure. If there's an actual exposure and the exposed individual either tests negative or their test results are unknown, you're going to code Z20.828. In other words, this one up here is encounter for observation, and this is contact with or exposure to the virus. So you're just going to have to read your documentation carefully to know which one to code. In the screening for COVID-19 for asymptomatic individuals, code Z11.59 would be coded, encounter for screening. If it's asymptomatic, see guideline G. If you have signs and symptoms without definitive diagnosis of COVID-19, this guideline is telling you you're just going to code the symptoms unless you know they've had exposure, and then you're going to code the Z20.828. Here's an example of signs and symptoms without a definitive diagnosis. And you see the patient has the fever, the shortness of breath, who was exposed, the hypertension, the anxiety, the diabetes, and the long-term use of insulin. Whenever a patient has diabetes, you want to read the documentation carefully to see if they're on oral meds or insulin, because you're going to be coding however they are treating their diabetes. So if you have an asymptomatic individual who tests positive, you are going to code the U07.1. Although the individual is asymptomatic, they've tested positive, so you're going to code it. And here's the Chapter 15 codes I was telling you about, where you've got complications in pregnancy, COVID-19, 098.52. You would use your COVID-19. This should say COVID-19 right here, not coronavirus. Weeks of pregnancy, Z3A.27. At the time I created this PowerPoint, everything was correct. I expect there will be changes, and these changes will be published in Coding Clinic as more information becomes available about COVID-19 or any of the other disorders. If you have any questions, post them in the discussion board. Thanks so much. Have a good day.